Okay, so here's your coronary artery, but there's a blockage. There's a big old blockage somewhere, okay, because I don't see a lot of that vasculature like I should. So they go in, they take their little wire, they go in, they do what they got to do, they pull out that clot or they break it up, and now look at all that perfusion. Okay, that's now occurring. So they have now reperfused the heart tissue. When you give aspirin and nitro, that's the beginning of the reperfusion. Remember, because nitro causes vasodilation, and so it increases the blood flow to that tissue. But the definitive treatment is to get your patient to a hospital that has an acting cath lab, right? So it has to be a cardiac accredited hospital. That's one picture. Let's look at another one. This is an awesome picture right here. Let me see. Here we go. Okay, do you kind of see that looks like it just looks like there's a break in it. Okay, so it's not flowing all the way through. Well, they just reestablish blood flow. Okay. So that's what happens in the heart. And you can look at all these. This is a really great one. This is a complete block right there. It is just it just stops, and there's nothing over here. They reperfused. They went in. They put in a stent. They open it back up. They suck that clot out, and look at now how beautifully reperfused this is. Okay, so that's what's going on when you have an acute MI. Okay, there's a partial or complete blockage, and it is all those cells that are distal to that where that blockage is. All those cells don't have oxygen and they're dying, and that's where your chest pain comes in. And the larger the clot, most of the time, the more tissue that is involved in the blockage, that will determine just how critical your patient is, if that makes sense, because you can have a patient who's having a heart attack that goes into cardiac arrest and doesn't survive. Okay, so again, very, very, very time sensitive. When you walk in and they're pale and ashen and diaphoretic and chest pain and, oh, it's terrible. Wow, that person is sick. Let's go. I can give them aspirin in the truck. I can get a blood pressure and vitals in the truck. Let's go. Okay, because they're going to crash, and I'm going to be doing chest compressions pretty soon. So very, very time sensitive. Make sure you know the difference between your angina and your acute MI. Angina is temporary, normally lasts 10-15 minutes, resolves with rest. And acute MI does not resolve with rest, needs to be reperfused at the cath lab, normally more than 15 minutes, normally over an hour, is a big deal. All right, moving on to endocrine, number 16. We got to get through this. I'm just talking and talking. Number 16, define the following diabetic emergencies, give the signs and symptoms of each. Okay, so we have 3 different emergencies that we're going to go over here. This is hypoglycemia. Okay, so make sure you know your medical terms, hypo and hyper. Hypo means low. We're going to talk about diabetic ketoacidosis, and then we're going to talk about HHNS, or your hyperosmolar hyperglycemic non-ketonic syndrome. Okay, so before we go into the emergencies that happen, let's talk about the normal processes real quick. Okay, so let's talk about a little bit of A&P and talk about the normal processes, because number 17 is talking about insulin, glucagon, glycolysis, and all these normal things that we should know. Okay, so if someone does not have diabetes, this is the normal process. You eat dinner, you eat lunch, you eat something, okay? And the glucose levels will rise in the blood from what you just ate. So the glucose levels increase in the blood. Your pancreas will secrete insulin into the blood to allow glucose to pass into the cells for energy. Okay, so this is really important. In order for your cells to use the glucose in the blood, insulin has to be present. The easiest way to think about this is if you're in, if you're in the classroom, right? and the classroom is the cell. All of the blood is out in the hallway, and all the glucose is out in the hallway. The only way for that glucose to get in is if the door opens, and insulin is the only one that can open that door. Okay, if you remember that, that'll help with this. So, normal process. Someone eats, their blood glucose levels increase, so there's more glucose in the blood. Your pancreas will secrete insulin into the blood to allow the glucose to go into the cells to be used for energy. That's the normal process. If you skip a meal, and we do sometimes, right? If you skip a meal, you get hungry. Your body tells you, okay? You start to feel it too. Your pancreas, because your pancreas is super important, your pancreas will then secrete glucagon, and glucagon will stimulate the liver. Now, the liver is important in this because the liver has these storages of glucose, okay? Just kind of hanging out, ready for if you do skip a meal. Okay, so your pancreas will secrete glucagon, and that glucagon stimulates your liver to release stores of what's called glycogen. And glycogen is basically a complex sugar of glucose, or a complex form of glucose. Okay, glycogen will go through a process called glycolysis to break it down into the most simple form of glucose that can now be used by the cells. Okay? So that's how all of this normally works. You eat, your pancreas secretes insulin, the insulin opens the door to allow the glucose to go into the cell to be used for energy. That's important to know. If you don't eat, you get hungry, your pancreas secretes glucagon, and your glucagon stimulates the liver to go through glycolysis for that glycogen to break down into glucose to now be used, okay? Because I didn't have any glucose because I didn't eat, right? So that's the normal process. So now let's talk about when there's a problem. If you have a diabetic patient, those processes aren't what's happening, okay? Hypoglycemia, pretty simple. It's in the name. Hypoglycemia is low blood sugar, right? Low blood sugar. And hypoglycemia is, or your patient will present with altered mental status, because remember, the brain needs two things. It needs oxygen and glucose, right? So you'll have altered mental status. Patient will be pale and diaphoretic, okay? Your blood glucose levels are low, and so you don't have enough glucose to support your cells and their functions, okay? How do we treat that? Super simple. We give them oral glucose. We've already talked about that. We give them oral glucose if their blood sugar is low and they are symptomatic, and if there's no contraindications present, right? Because remember, they have to be able to swallow and all that kind of stuff because it's an oral medication. Okay? Diabetic ketoacidosis, this is a form of hyperglycemia. So these two right here, HHNS and diabetic ketoacidosis, or DKA, these are both hyperglycemia, okay? Hypoglycemia is kind of standalone. Okay, so these are both high blood sugar levels. So DKA, or diabetic ketoacidosis, that's when the blood glucose levels are high. Now, this is important because this deals with insulin and all that stuff that we just talked about, okay? Your patient that experiences DKA is typically your type 1 diabetic patient. Your type 1, remember you have a type 1 and a type 2. Your type 1 diabetic patient their bodies don't produce insulin. And if you don't have insulin, then that glucose can't go from the bloodstream to be used into the cell. So if you don't have insulin, then what is your cell going to use for energy? And that's where this DKA comes in. So your blood glucose is typically high, typically over 350 or something like that. When you prick their finger, you'll get something over 300. All right. And because that glucose is out and stays in the bloodstream, there's nothing that's coming into the cells. So the cells are starting to starve. Kind of think of it that way. The cells are hungry. They're starting to starve. And since glucose is not available because there is no insulin, so no one's opening that door, they turn to something else. They turn to a different source, and they start to burn fat. Okay, they're starved. They don't have glucose, so they start to burn fat. Now, if you know your metabolism and all that kind of stuff, when fats are metabolized, they produce ketones. Okay, and ketones is not something that I necessarily want to be, built up and produced in my body. Okay, if I have too many ketones, I start to have problems. So, as these ketones are produced in your body, you're gonna basically go into like a respiratory acidosis or metabolic acidosis. And so your respiratory rate is going to increase because you're going to try to exhale or blow off those excess ketones. And you're going to have a very distinctive respiratory pattern called Kussmaul's respirations. Kussmaul's respirations, that is Kussmaul, Kussmaul's respirations, okay? This respiratory pattern is a rapid, deep respirations, like really, really rapid, really fast. If you keep doing that, you're going to pass out kind of thing, okay? But they're doing that because they're trying to blow off these ketones that are being produced in their body because their cells don't have glucose and they're burning fat, okay? Some people think that odor, there's an odor to their breath. It's kind of a fruity odor or a fruity smell, and that's the ketones that you're smelling. Okay, the best way I can describe it smells like mango. Okay, so DKA or diabetic ketoacidosis, and that'll help you kind of diabetic ketoacidosis. This is hyperglycemia, where there is no insulin or not enough insulin present. You can think of it that way, to assist moving glucose from the bloodstream into the cells. And if the glucose stays out in the bloodstream, then that means when I prick their finger, I'm going to have a high level of blood glucose, but there's nothing in the cells. And so the cells metabolize fat, they produce ketones, and my body's trying to get those ketones out. So I'm going to have those Kussmaul's respirations. Okay, this patient is not going to feel well. They're going to feel sick. They're not going to feel well. Okay. How do we manage that? ABCs, airway, breathing, and circulation, and we got to get them to the hospital. I'm not going to give them insulin. We don't know that. We don't understand that. Everybody's insulin levels are different. There's sliding scales. There's all kinds of different things. So the treatment is managing the patient and getting them to the hospital. Okay. Now your HHNS, or your hyperosmolar, hyperglycemic, non-ketonic syndrome, it's hyperglycemic, okay, and it's non-ketonic. This is important. This is the only one, DKA is the only one that produces ketones, okay? This one does not. It's still hyperglycemic, but it's non-ketonic. So let's talk about HHNS. So HHNS is another form of hyperglycemia. So when you prick their finger, their blood glucose level is going to be really high. And HHNS is even higher than DKA. HHNS is normally above 600, 700, that kind of thing, okay? You can have patients with a blood sugar over 1,000. Let's see here, long time ago, when my grandfather, when he was still alive, when he first found out he had diabetes, his blood sugar was over 1,100. Okay. I've in some CPR classes that I've taught, we've discussed multiple things, and I've had people come up to me and say, "Oh, a family member just found out they have diabetes, or this or that or whatever." And there was one a couple months ago, and they said that their cousin had a reading of over 1,200. So I'm telling you, your blood sugar can get really, really high. But this isn't something that just goes, it's okay today and tomorrow it's over 1,200. No, this is something that kind of develops over time. Okay, but let's talk specifically about HHNS. So it's hyperglycemia very high blood sugar readings. When you take their BGA on that glucometer, it only goes so high. So most of the time it'll actually have the word high, HI, on your glucometer. It won't even give you a number. Okay. So this, because it's non-ketonic, it means that there is enough insulin in your patient's body that there's glucose moving from the bloodstream into the cells to be utilized for energy. So the cells don't have to use fat and they don't produce ketones. So there is enough insulin for that process to work normally. The problem is that they just have too much glucose in their blood. That's where the problem comes in. Okay, is that their blood glucose levels are just way too high. And what starts to happen with this is your kidneys, which are great because they filter our blood and they help with all that kind of stuff. Your kidneys are going to recognize that, hey, we've got way too much glucose in our body, in our system, and I need to help. I need to do something about it. So I'm going to start filtering this blood, and I'm going to start excreting glucose in the urine. Okay, I'm going to get it out of the body. But the problem is it doesn't just excrete glucose. It has to excrete fluid with that, right? So as your kidneys are trying to get rid of all this excess glucose, they're also getting rid of fluid. So the problem is you can go into hypovolemic shock from HHNS, from having too high of blood glucose levels, because your kidneys are just churning away, trying to get rid of this excess glucose, trying to get us down to a much more manageable level, but they have to excrete fluid in order for the glucose to leave. So you're going to see something called the 3 Ps. You're going to see polyphagia, polydipsia, and polyuria. Okay, poly means many. Polyuria is frequent urination. Makes sense. My kidneys are working overtime trying to get rid of this excess glucose, and so I'm going to be peeing out a lot. Okay, frequent urination. Polydipsia is increased thirst. Because you're getting rid of so much fluid, you're thirsty, right? You're thirsty. Your body is telling you, hey, we need to drink something. We need to bring fluids in. We're getting rid of too much of it. And then polyphagia is increased hunger. Okay. So if you have someone, and this is a lot. Okay. This isn't just like, I went to the bathroom a couple extra times today. No, this is like, you can't quench your thirst and you're constantly going. Okay. And it's noticeable where you go, this is way too much. I am way too thirsty and I'm going way too much to the bathroom. Okay. So, the mortality rate of your HHNS patients is a lot higher than DKA because of the possibility of that severe dehydration and severe hypovolemia. They can go into hypovolemic shock because they're getting rid of so much fluid. Okay. Remember, there's enough insulin present in HHNS. There's enough insulin present to open the door and allow glucose to come into the cells, so the cells are functioning appropriately. You just have way too much glucose in your bloodstream. So your kidneys kick in, say, we got to get rid of this. I'm going to get rid of the excess glucose, but fluid goes with it. And so you have polyuria, frequent urination, polydipsia, increased thirst to replenish the fluids that you're losing, and then polyphagia, increased hunger. Treat your patient ABCs. Be prepared for hypovolemic shock because they're losing volume. Okay, so hypoglycemia, DKA, HHNS. Very important to know the differences between the two. Also, hypoglycemia is going to be cool and clammy skin. DKA and HHNS are going to be warm skin. Warm skin. They're not going to be cool and clammy. They'll be warm. All right, so we talked about insulin. We talked about glucagon and how all that stuff. Pancreas secretes insulin. Pancreas secretes glucagon. Your liver has all those excess storages of glycogen. And so that glycogen goes through glycolysis to break it down into your basic glucose to be used by the body. There's your polyuria, polydipsia, polyphagia that we talked about. That occurs with your hyperglycemic emergencies. Okay, so make sure you're good with that. Okay, number 19. Moving on, allergic reaction, anaphylactic shock. Okay, allergic reaction is going to be your one body system, right? And anaphylactic shock is multiple body systems, including, or two, if you want to think of it as more than one, so two or more body systems, including your respiratory. Okay, anaphylactic shock is where you have that uncontrolled histamine release, and so the histamine is acting upon the smooth muscle of your blood vessels, and it is causing that systemic vasodilation, and so your patient has the potential, for going into distributive shock. An allergic reaction, because it's only one body system, whether it's GI only or skin only, but it's not respiratory, then we're not worried about distributive shock. We're just worried about, figuring out, getting a good sample history and figuring out what this patient could possibly be allergic to, right? There's no respiratory involved, so I'm not worried about airway swelling or stridor. That stuff comes with my anaphylaxis. And I treat my anaphylaxis with epinephrine. Okay? I think, maybe I'm going to totally prove myself wrong, but I think it might be in these lookalikes. So there's your CVA and your stroke. DKA versus HHNS, right? Type 1 versus type 2 diabetics, very high versus high. Signs and symptoms, blah, blah, blah. Croup, that's for kids. That's good to know. Nope, it's not in here. Yep, allergy versus anaphylaxis is not on here, but if you've done your emergency charts, then you know what we're talking about, okay? Okay. What are the functions? Number 20, we know what the heart does, right? The heart is what pumps the oxygenated blood to the rest of the body. You need to have that cardiac output. It's very, very important. The pancreas. The pancreas is located in the right upper quadrant and the left upper quadrant, so it kind of spans both. It's just behind the stomach. It does aid in the digestion and regulation of carbohydrate metabolism. Right? All that stuff we just talked about with your endocrine system, with the glucose. Pancreas also produces your insulin and your glucagon. Like we said, it helps with the metabolism of the carbs, of the metabolism of your glucose. Okay. Your kidneys are paired organs. So I have got two of them, right? They're located in that retroperitoneal space behind the abdominal wall, one on each side. I like to call it my flanks, right? You're going to hear people are going to say, man, I've got this pain right here. And it's kind of their mid back on the left or right side. That's where your flanks are. Okay. Your kidneys, they filter the blood, right? They help filter the blood. They're going to excrete urine. They regulate water, electrolytes, and your acid base balance. They help to regulate your blood pressure as well because of the water. They can remove sodium from the body. Okay. They're going to do all that kind of stuff. Your liver is the large solid organ that sits in the right upper quadrant just beneath the diaphragm. It also helps to filter nutrients from the blood as it returns from the intestines. It stores your glucose in the form of glycogen. It's going to filter dead red blood cells. It helps with metabolism or metabolizing medications. There's something called the first pass effect of medications. So whenever we take oral medication, pills and things like that, it will be metabolized by the liver first. So if you overdose on something, it causes major liver damage. Okay. Remember, your gallbladder lives kind of within the lobes of your liver and secretes the bile and aids in the digestion of fats, right? But that liver is in that right upper quadrant. Number 21 was the patho of all these little things. We've got TB, which is tuberculosis. Okay, tuberculosis is an infection in the lungs. The bacteria that actually causes tuberculosis is called Mycobacterium tuberculosis. Most patients are asymptomatic, okay? Most patients are asymptomatic. The respiratory droplets, okay, this is spread by droplets. Those droplets are really, really small. And that's why it's important to protect yourself by wearing masks, specifically an N95 mask that's kind of fitted to your face, and it has much smaller, like, I don't know, it's kind of hard. Think about the thread count, it's got a higher thread count. And so there's smaller spaces in between the materials of your mask. And so these small respiratory droplets can't get through. If your patient is symptomatic, then they'll have coughing, night sweats, unexplained weight loss, low-grade fever. Okay, we do regular skin tests, regular TB skin tests for EMS providers annually. Okay, most medical providers will do an annual skin test or some kind of test to make sure that they haven't been unknowingly exposed to TB. Asthma, we've talked about. Well, I guess we really haven't talked about asthma itself, but asthma is a respiratory emergency that most patients have some kind of trigger, whether it's pet dander, it could be exercise, it could be cold weather. There's so many different things that can trigger a patient's asthma to flare up. But when that happens, they have bronchoconstriction and bronchospasms, which presents itself with wheezing. And so if your patient is wheezing, then we will need to do airway management and give them an albuterol treatment, right? Your hepatitis, you have a couple different ones, but your hepatitis in general is an inflammation of the liver, hepatitis, right? Inflammation of the liver. Hepatitis B is transmitted through the blood, through sexual contact, saliva, urine, breast milk, things like that. Hepatitis C is transmitted also through blood and sexual contact. Both can be transmitted from long-term carriers. The reason why we worry about B and C is because of the blood contact and, sometimes what we work with patients. So it's all about crew safety. But some of the symptoms that you would see with a patient that has hepatitis is loss of appetite. They may have a low-grade fever, vomiting, fatigue, sore throat, and cough and muscular pain. Pain in the right upper quadrant where that liver lives, right? Where that liver is actually situated in our abdominal quadrants. And then jaundice, which is where we get that yellowish tinge to the skin, that actually will occur a little bit later on. That's like a late sign, okay? If you want to see all the different forms of hepatitis and what their different signs and symptoms and presentations are, you need to go to table 15-2. So 15 is going to be chapter 15, table 15-2 for your hepatitis. Pancreatitis makes sense. Inflammation of the pancreas, right? And we already talked about where the pancreas sits. It kind of is split between the right upper and the left upper quadrant, sits behind the stomach. Your patient will experience pain, tenderness, and distension. The pain may radiate to the belly button. You could have signs of shock from fever, pain in the upper abdomen, both quadrants, that kind of thing. Alcohol abuse can cause pancreatitis, things like that. Stomach ulcers. This one's kind of interesting. I don't know if any one of you have ever had a stomach ulcer, but it's painful. And because basically what's going on is, I want you to think about what's in the stomach. When we eat, all that food has to be broken down by acid, and that stomach acid is pretty it's pretty intense, okay? And when you have a stomach ulcer, then that means the protective layer within the stomach, like the lining of the stomach, that protective layer has eroded and it's no longer present in certain places. And so that stomach acid is actually touching and coming into contact with the organ, with the stomach tissue itself. And that stomach acid is actually eating into the organ. Okay. Your patient will experience a burning and gnawing pain in their stomach. Their stomach, remember, is in the left upper quadrant. Okay. But that burning and gnawing pain will actually subside after they eat, because now, when you take in food, that stomach acid isn't as concentrated because it's now mixing with the food and all that kind of stuff. And so the pain will subside a little bit after you eat. But after your stomach empties, a couple hours later, the pain's going to come back because now your stomach acid is so concentrated because there's no food in your stomach. Also, your patient will have could possibly have nausea, vomiting, belching, heartburn, things like that. But if they're like, man, it's this gnawing pain, it just won't go away, but it feels better when I eat, there you go. Stomach ulcer. Okay. Esophageal varices. This is very interesting, has a high mortality rate. Esophageal varices, this is your esophagus, okay? Basically tears, large tears in the surface of your esophagus from an increase in the pressure of the esophageal vessels, okay? This is normally paired with liver failure, okay? That pressure in the esophageal vessels is actually occurs from liver failure. There's heavy bleeding in a patient's esophagus, enough to the point where it causes hypovolemia, and it causes a lot of airway issues. So there's large amounts of bright red blood that they're vomiting, and I can never say this word, but it's hematemesis, hematemesis, right? Hematemesis, where they're vomiting blood. Your patient's going to have a rapid pulse. They'll be tachycardic. They'll be short of breath because that blood that's coming up and out is, partially blocking their airway. Signs of shock, signs of hypovolemia, pale and clammy, and they'll probably also be jaundiced because that's where that, liver failure, that's kind of where it starts. Okay. You're going to be doing a lot of suctioning, rapid transport. You can't stop it. So a lot of suctioning, rapid transport, get them to the hospital. All right, number 22, kidney stones. So we know where our kidneys are. That's in the retroperitoneal space, or those flank areas, right? So a kidney stone, you're going to have right or left. Hopefully they only have one going on at once. Right or left flank pain, and that pain will radiate to their genitals, okay? Because you have to follow the path of the ureter, right? That leaves the kidney and goes all the way down into the urinary bladder, right? It takes the urine from the kidneys down into the urinary bladder. Okay. So when we talk about our OPQRST, and we're talking about radiation, this is one of the ones that, the pain may move. So it's really important to have all that stuff. Or to ask all that stuff, because if they say, man, my back was hurting really bad, and they kind of point to their left flank, that retroperitoneal space, and they're like, man, it was hurting really bad right here, but now it's kind of moved around to my side, and it's getting kind of down, down a little bit lower. That's because the stone is moving. Right? It's a calcification that occurs within their kidney. And if it's small enough, it'll move. If it's large, then it won't move, and it'll either need to be surgically removed, or they may have to go in and break it up into smaller pieces. So the person will have to pass the multiple smaller pieces. Okay. But it's that pain, flank pain radiates to the genitals. You may or may not see bleeding in the urine. A lot of people think, oh, you got a kidney stone, then you are gonna visually be able to see blood in the toilet. And sometimes, most of the time, that's not the case. The blood that you see that is in their urine is microscopic. So that's not always the case, but that pain, obviously, and it's pretty bad. It's pretty bad pain. Gallbladder sits in the right upper quadrant with the liver, okay? So the gallbladder has bile, which helps to break down the fats that we consume. The problems with the gallbladder is going to be gallstones, Okay. Another thing is cholecystitis, which is inflammation of the gallbladder. Okay. Inflammation of the gallbladder or cholecystitis happens because of gallstones. Those stones form in the gallbladder and they block that bile outlet that causes inflammation. The signs and symptoms that your patient will experience is going to be tenderness in the right upper quadrant, belching and heartburn, nausea, vomiting, and they'll most likely have increased pain after eating fatty foods. Okay. So that's why, asking the L, what's the last thing you ate? That's another reason why, right? So there's a lot of these medical emergencies have little little red flags that, if you ask your questions and you get that piece of information, you're like, okay, hang on, that might tell me what's going on here. It's very distinctive pieces of this stuff. Now, something also about cholecystitis, it often occurs in patients normally 30 to 50, around there. It is predisposed to women, okay? And I'm gonna say this, and I don't mean to offend anybody, but I want you to think about the 4 Fs: fat, 40, fertile, and female. Okay. That is kind of your prime candidate for gallstones. I'm not saying everybody that fits that description is going to get it, but that's kind of your, it's a little crass, yes, but it's an easy way to remember it. You're kind of overweight. Females that are in their 40s may or may not, still be maybe perimenopause around there. Still fertile. So still having their cycles. Female, that's kind of your main, suspect, if you will. It can happen to anybody, but there you go. Appendicitis, your appendix, remember, is in your right lower quadrant. Appendicitis, that's inflammation of the appendix, right? Okay. So when it's inflamed and it's infected and just bothered, right? Signs and symptoms will be periumbilical pain. So periumbilical, around the umbilical or around the belly button. Pain that around the umbilical that localizes to the right lower quadrant. You'll have that rebound tenderness. Right? And rebound tenderness, remember, is when you palpate the stomach, and you always palpate the stomach when you have a patient with abdominal pain. When you palpate that right lower quadrant, the pain is not when you push in, but when you release the pressure. Okay. Your patient will also experience nausea, vomiting, kind of a low-grade fever, lack of appetite. They'll be guarding their abdomen because they're not going to feel very good. If they don't call 911, if they don't seek some kind of, help, and that appendix bursts, then when it ruptures, it releases all of its contents into the abdominal cavity. It can cause major infections, and your patient can actually, they can die from that. So that, and sometimes, you may have, I'm just going to talk about him. He's my husband. I can say it. He had his gallbladder out a couple years ago. He's, he doesn't complain he does, but he doesn't complain when things are really bothering him. He was just like, man, it's just really bothering me. I just don't feel good. I feel sick to my stomach, and I don't know what's going on. I have this low-grade fever. Low-grade meaning, it's going to be like below 101, right? Low-grade, and he had this pain just in the center part of his stomach. But as it kind of progressed a little bit, it was getting more down towards his right lower quadrant. And then at that point, you kind of go, okay, maybe this is what's happening. We got him into the hospital. Next day, they took it out, and the doctor said that, it was close to bursting. So you just never know. Remember when I said everybody's pain threshold is different? That's why we have to ask all the questions that we ask, right? And then myocardial infarction, we already talked about that, but just remember that's a heart attack, right? That's when you have your occlusion in your coronary arteries, one or more of your coronary arteries that feeds the heart muscle. Those heart cells are not receiving oxygen, so they're starting to die. and that's where we get the pain from. And the pain is going to be a lengthy amount of pain until that occlusion is removed from the hospital. Got to know where all your organs are. Okay, back to the abdomen. Right upper quadrant, liver, gallbladder, pancreas. Some of the colon is up there, right? You got your intestines. Left upper quadrant, stomach, spleen. Again, your pancreas. More intestines. Right lower quadrant, you've got your large intestine, your appendix. And if you're a female, you have your right ovary. Left lower quadrant, got your intestines. And if you're a female, you have your left ovary. So just make sure that you know where your organs are. Different positions. Number 24, the positions of transport. We're almost done. Getting there. Prone. Remember, this is literally from like day one when we were talking about medical terminology. Prone means face down. Remember, face down. And you're not ever going to transport your patient in a prone position. You may find them in a prone position, okay? And when you find them prone, you have to turn them supine, because if you keep them prone, then that means you can't manage their airway, you can't assess their airway, you can't see what's going on with those life threats. So you have to move them to a supine position. Supine meaning laying on your back face up. Okay, so if I had an unconscious patient that I was doing airway management, bagging them, suctioning, things like that, they're going to be supine. If you have a patient who is on a backboard, which we'll talk about in Mod 3, they'll be supine, right? But you have to think about all that kind of stuff. Semi-Fowlers is when they're kind of lounging back you have the head of the bed or the head of the stretcher at like a 45-degree angle. That's semi-Fowlers. And then left lateral recumbent. This is also what we call like the recovery position. Left lateral recumbent, meaning they're laying on their left side. Okay. This patient is someone that is going to be, this patient is normally unconscious, but their airway is intact. They have a clear airway. I don't have to manage their airway, because if I had to manage their airway, then I would need to place them in supine, right? But they're not. So they're on their left side. They're normally unconscious, not injured, and breathing adequately. So that's why we call it like the recovery position, okay? It helps us maintain their clear airway. They're breathing adequately, and by being on their left side, it helps us maintain their clear airway. When we are restraining patients, how to restrain versus when not to or how not to. So when you restrain a patient, the proper way to do it is supine on a backboard. Okay, you want to have one arm up and one arm down. And let me kind of pull this up and pull up a picture for you. Okay, patient restrained on backboard. Okay, so don't restrain them like this with both arms down at their side, because if you and this is, I'm talking about the cuff restraints. Okay, so we've got their hands tied to the backboard. If you put both at their side, then they can use their muscles, they can use their biceps, and they can basically use it as leverage to get their upper body and bring their upper body off of the backboard. What you want to do is do this, where you have one arm down and one arm up, because by having this one arm up, it keeps them from being able to pull themselves up off the backboard, come up off that backboard. Okay, so the proper way to do this would be supine, one arm up, one arm down. Okay, just like this. You really need to be careful about this strap right here, this strap that goes over their chest. You want to make sure it's not too tight, because you don't want to restrict their chest wall movement and therefore affect their breathing. Okay, super important with that. So never put any straps over the chest. because of the risk of issues with their respiratory and their ventilations, right? And always monitor that airway, because if they're laying flat and you have them, if you have them restrained flat supine on a backboard, then if they vomit, then they can't turn over, they can't, clear their airway. So you need to monitor it and suction. The reason why I say supine on a backboard is because if this patient is combative, okay, and we've restrained them because they're combative, and we do it because they're a danger to themselves or others, then if I tie them to the stretcher, what do I have to do when I get to the hospital? I have to untie them, right? So instead, let me tie and restrain them to a backboard. So when I get to the hospital, all I have to do is move the backboard from my stretcher over to their bed, and I don't have to adjust the restraints or untie or loosen anything like that, right? So that's why we say supine on a backboard. When do we do it? Like I said before, when the patient is a danger to themselves or to others. Also, when verbal de-escalation techniques aren't working. Okay. And I'm pretty sure there's something in your Canvas that talks about some verbal de-escalation. I'll make sure and find that for you guys. It's not on your test, but it's definitely good to at least review. When do we not restrain? Basically, you don't want to restrain your patient if it's going to make the situation worse, or if they are, let's see here. The biggest thing is if it's going to make it worse. Okay, so if you feel like by restraining them, this is going to escalate into something worse, then just get law enforcement involved and have them assist you. Okay. All right, now let's talk about drugs. Okay, stimulants versus depressants. So first off, let's talk about what is a stimulant. A stimulant is something that stimulates the sympathetic nervous system. Okay, so again, from Mod 1, if you know what that sympathetic nervous system is and what happens when you stimulate it, then you'll understand what happens when a patient takes or ingests a stimulant. Okay, it causes it causes tachypnea, it causes hypertension, it causes tachycardia, anxiety, diaphoresis, dilated pupils. Okay, increased body temperature. Your patient cannot regulate their own temperature, so they're at a risk for heat stroke. Okay, paranoia. They're at a very high risk for arrhythmias because of what it does to their heart, right? It increases all that. Some specific examples of stimulants: cocaine, meth, PCP, other amphetamines, ADHD medication, ecstasy, and caffeine. Gotta love that caffeine, but caffeine is a stimulant. And if you take too much of it, or if you ingest too much of it, whether it's in coffee form or energy drinks or all that kind of stuff, it can mess you up. Okay, so you gotta be careful about that stuff. So stimulants are things, right? That stimulate the sympathetic nervous system. Depressants do the opposite. Okay, so depressants are what depress our nervous system, and it's going to cause drowsiness, respiratory depression, hallucinations, seizures, things like that. Examples would be like marijuana, K2, alcohol, your date rape drugs. Those are all forms of depressants. Okay, opioids, like what we talked about with our for our Narcan or narcotics, right? Because narcotics produce sleep or alter mental status. So opioids that we use to relieve pain, those also cause drowsiness, respiratory depression, right? Pinpoint pupils. Okay, but make sure you know stimulants versus depressants. Psych. Paranoia. Explain and give symptoms. I'm sorry, it's almost 1 o'clock in the morning. Okay, and thank you guys for hanging out with me. If you're still here, that's fantastic. Paranoia is an unjustified suspicion or mistrust that somebody has. They have delusional beliefs of persecution and threats. So delusional, which means those are not, those are not real, but they truly believe it, right? And that paranoia really is just affecting their, their life and how they're living their life at that moment. Schizophrenia is a common disorder that involves the significant change in behavior. It affects how a person thinks, feels, and behaves. This patient will have hallucinations, delusions, depression, paranoia, erratic speech, withdrawal from social interaction. Okay, schizophrenia, the typical onset for schizophrenia is between 16 and 30 years old. Okay. Bipolar, this patient will experience alternating periods of depression and manic behavior. They can be irritable or elated, energetic, quickly becoming argumentative and hostile if they're challenged. They have a decreased need to sleep when they're, at that manic behavior. Okay. Depression is that profound sadness or feeling of melancholy with a loss of interest in everyday activities, weight loss. Again, you've got insomnia and stuff like that. And your panic attack, last one, is sudden anxiety or extreme dread that's unprovoked or related to a particular stimulus. Your patient can experience chest tightness, shortness of breath, hyperventilation, palpitations, dizziness, sweating, things like that. Okay, when you have a patient experiencing a psychiatric medical emergency, remember your ABCs always come first. So if those are okay, then you kind of switch to listening, supporting, protecting yourself and them from themselves, right? Maintaining a calm environment. Sometimes sometimes law enforcement is not the best people to have on that scene, but they kind of have to be there. So just talking to them and getting them to the help that they need. Let's talk about suicidal ideations, AMA or against medical advice, refusals, and that kind of thing. Some of the things that you should do when someone is suicidal, can we leave them alone? So if you remember your medical legal stuff and your consent, you have your patient who is awake and alert and oriented and able to make good decisions or understands what you're talking about, is able to make sound medical decisions. If you have a patient who is suicidal, whether they have what we call suicidal ideations, where they're thinking about doing it, or if they've actually acted upon those thoughts, then those individuals are considered not competent to make medical decisions for themselves. So a patient who is suicidal is not competent, okay? Not competent for me to allow them to refuse. So they cannot, if they tell me that they want to harm themselves, or if they have tried to harm themselves, then they cannot refuse transport to the hospital. Okay. Can we leave them alone? No. Can we leave them against medical advice, which is AMA? No. They cannot sign for themselves because they're not in the right mindset to make good decisions. Now, here's the thing. I can't force that person, or we can't force that person to go with us in the ambulance. I can't legally do that. So you have to get law enforcement involved. Okay. And law enforcement is going to app that patient. We call it apping. That's short, but it's APOWW. APOWW. That is apprehension of the police officer without a warrant. So basically, this police officer is taking this person into their custody because there's some kind of mental illness or chemical dependency or something like that, where the patient poses a risk to themselves and others. And they've, like I said, they've said they've made some kind of mention of ideations of how they want to harm themselves or they have already tried to. So that person cannot sign. They can be awake and alert, able to answer all of your questions, right? But because they have suicidal ideations, they have legally lost their right to refuse. I cannot wrestle them in the back by myself. I don't have the authority to do that. I have medical authority. I don't have legal authority. So you have to get the police involved, and the police will app the patient, take them into their custody, and that gives us the authority to transport them to the hospital. Okay. So just make sure you understand that. Last but not least, alcohol or drug withdrawals. Okay, you might know the term delirium tremens, okay, DTs. So when you have a patient who has a long-standing relationship with alcohol or certain drugs and their body is used to having high levels or used to having it in their system, when they don't have it in their system, they will go through withdrawals. And it's a pretty big physical thing that happens to them. They get physically ill. Okay, agitation, restlessness, fever, sweating, confusion, disorientation, tremors. That's why we talk about delirium tremens. Okay, seizures, delusions. They will go. It's bad. Okay, so if someone is trying to kind of, get off or get clean of something, and their body, and it just, depends upon how long they've had it, but if they've been using or ingesting this substance, whether it's alcohol or medications or illicit drugs, if they've been using that for a while and their body's used to it, when they stop taking it or stop ingesting it, then their body has a physical response and they are physically sick and ill, and you may get called for that. Okay, so a lot of that is ABC management. If they're having seizures, we talked about seizures already. How do you manage a seizure? Think about that. If they have confusion or disorientation, if they're sweating, if they have agitation, you're just supporting them and getting them to the hospital. Okay. Hazardous materials. This is the very last one. Almost there, guys. Almost there. Hazardous materials. If you've got dry powder, then I don't want to add water. I want to brush it off. Okay. Brush it off of their skin, brush it off of their clothes. They probably need to remove their clothes, because if it's, I just need to remove the dry powder, get it off of them. If I flush them with water, with that powder still on them, then that powder can react negatively with the water and make it worse. So I need to get this stuff off the patient's skin. If it is wet, like bleach, then I need to flush with water, right? Then I can use water to remove the substance from them. Normally I flush with water for at least 10 minutes. Okay. Think about if it gets in the patient's eyes or anything like that. Think about when you were, back in grade school, or you guys might even have this depending upon what kind of college classes and labs that you take. Think about, like the first aid station, and the eye fountain, right? They have a little eye fountain where, if you get something in your eyes, you're supposed to stick your face down in there and it flushes your eyes, right? That's what this is too. We're flushing it off their skin. We're getting rid of the wet chemicals that's on them. But if it's dry, you brush it off. You brush as much of it off first. Okay. That's a lot, but that's your medical emergencies, because there's a lot. All right. Make sure you know your BLS. Make sure you know your respiratory distress versus respiratory failure, because if your patient's experiencing cholecystitis or appendicitis and they stop breathing appropriately, you got to breathe for them, right? You have to recognize if they go into respiratory failure, and you have to still manage those life threats. Think about your patient assessment, thinking about your A&P. Anything that we talked about in Module 1 is going to be a part of this in some way, right? It's going to be a part of this. So just make sure that you understand that. Your emergency charts are a great resource for this exam, because your emergency charts go through those very specific medical emergencies with the signs and symptoms and how we treat them and how we recognize them and all that kind of stuff. If you can get those done and make like flashcards and stuff out of them, that would be great. Okay. But just get those done. Do your Mod 2 group quiz. That needs to be done as well. Do your pharmacology chart. Remember, you got to know everything about the drugs that we give. And good luck. And I will see you guys next class. Okay. Y'all know where to find me. This will be recorded for a week. After today. Today is Sunday, now it's Monday the 16th, but Sunday night is when we started it at 10 p.m. It's now 1 a.m. on Monday morning, so it'll be good for a week. All right. The exam is 50 questions. You get an hour. Every module exam is the same, 50 questions, 1 hour. The capstone is different. Have a good one. Go to bed. That's where I'm headed. All right. We'll catch you later.